Good afternoon, everyone. I hope you're all having a great day, and I think we're going to make it better for everyone today with you joining our CanVector National Thrombosis Seminars. I'm Agnes Lee, and I'm going to be hosting our 1-hour seminar today. And those of you who've joined us before, you'll know that this is a new National Thrombosis Seminar series that's hosted by CanVector, and they are running throughout the year. And I think this is our third one, and we certainly have great feedback from everyone. The focus of these lectures is to really look at sort of state-of-the-art evidence in thrombosis, and they will be given by both Canadian and international experts. All of these seminars will be recorded and available online at CanVector if you do miss them, and these seminars are also accredited by the Royal College, so you can submit for your Section 1 accreditation afterwards. I want to thank the planning committee, including myself, Dr. Leslie Skeeth, Dr. Miriam Kimpton, Dr. Mara Kulian, Dr. Vinay Ben-Gareth, Dr. Mark Carey, and Nicole Langlois. Sorry, probably butchered her name. I'm sorry, Nicole. And we have the pleasure today of presenting today's lecture on statins and VTE research. I think this is actually really timely as well, given the potential role for certainly, immunothrombosis in COVID. So we'll bombard Peter and Oriane with these questions. So we have Dr. Peter Gross, who's going to start and talk about the pleomorphic properties of statins and why they may alter DVT and post-thrombotic syndrome. And then Oriane Duluc was going to present his study and talk about do statins prevent venous thrombosis. So we're going to basically collect questions and answers throughout the presentations in the Q&A module in Zoom. So we will not be addressing questions during the talks, just so we can get through things, because everybody is busy, and so just not to disrupt the presentation. So you can submit them anytime, and then we'll address them at the end at the last 15 minutes. So without further ado, I'm going to introduce Dr. Peter Gross. So Dr. Gross did his undergrad in biochemistry and got his MD from the University of Toronto. He did his core internal medicine training in Toronto, and then went to Beth Israel Deaconess at Harvard, did his fellowship there. He was the clinician scientist in the Department of Medicine at St. Mike's Hospital, and then he joined McMaster University, and he's currently an associate professor there. He is the head of the clinical thrombosis service at Hamilton Health Sciences, and his basic science laboratory is at TARI and focuses on the models of thrombosis and hemostasis and biomarkers for these conditions. He's obviously involved in lots of other research, and certainly in many clinical trials in thrombosis. And Dr. Oriane Duluc is a professor of medicine and a clinician, scientific clinician in the Department of Medicine at the University of Ottawa. And following his academic training in France, Dr. Duluc was appointed a professor of internal medicine at the University of Western Brittany in France. And his research interest is in epidemiology of thromboembolic diseases, particularly the link between arterial and venous thrombosis and the association between cancer and disease thrombotic and venous thrombosis. So he's continuing his research in Ottawa now, and right now he's particularly interested in fragile populations, so vulnerable populations who are who suffer from thrombosis and exposed to anticoagulant drugs. So again, thank you, Peter and Oriane, for giving the talk today. So I'm just going to pass on the control to Peter.
Thanks, Aggie. So the learning objectives of this sort of basic science introduction to statins and venous thrombosis is to understand how statins might have effects other than lowering cholesterol, to appreciate the limitations of models of DVT and models of post-thrombotic syndrome. So some of this work was funded by Heart and Stroke Foundation of Ontario. There's no other relevant disclosures. So what we're going to do is go through the pleiotropy of statins, the molecular mechanisms of the pleiotropy, go through some of the work we did in my lab about the antiplatelet effect of statins, and then go through a couple of papers that discuss a mouse and a rabbit model of DVT and DVT inflammation and statins. So statins inhibit HMG-CoA reductase. They effectively lower cholesterol. We've known this for a very long time. And they have a proven benefit in reducing mortality from atherosclerotic disease. And in most developed countries, they are the most prescribed class of medication. If you add all the statins up in Canada, they're the highest group, the highest class of medications prescribed in Canada. So these are two of the arterial thromboembolic events showing the benefit of statins on the left, one of the earlier studies, and then a study on the right where two statins of different doses were compared, suggesting a bigger effect with a higher dose of atorvastatin. The Jupiter trial, and Dr. DeLuc has this slide and also, so I'm going to not spend a lot of time on it. The Jupiter trial took patients with high CRP but normal cholesterol, randomized them to rosuvastatin or placebo, and measured outcomes. They measured venous thromboembolic outcomes, and there was a significant 50% reduction in all venous thromboembolic events. The statistical significance dropped away when it was unprovoked events, but was maintained for provoked events. They're lower numbers, obviously. Okay, so why should we still care about statins? So they improve cardiovascular endpoints, even in those who don't have increased LDL cholesterol. So they have other mechanisms. Something else that points to it is that the evidence for other mechanisms of lowering LDL in improving cardiovascular endpoints is weaker than with statins. So ezetimibe lowers LDL also, but has less effects on mortality with that lowering of the LDL. So what statins do is they block the biosynthesis of farnesyl and other molecules. And farnesylation is a common post-translational modification of proteins. If you want to go to sleep for the next 10 minutes, you're welcome to, because we're just going to go into that in a little bit more detail. So here's the cholesterol biosynthetic pathway. When I was in undergrad biochemistry, the professor who taught this was quite funny. And he said it's like building a house out of Lego. So you have these two carbon molecules, acetyl molecules, and then you join them together, acetyl, and then you get 4, and then you join them together, and you got 8, and then you keep going until you got a 16 carbon cholesterol. All right. So that's really how this happens. It's like an assembly of Lego, and statins inhibit the conversion of HMG-CoA to mevalonate. I've never been able to pronounce that well. And then farnesyl is the sort of second step before cholesterol, farnesyl pyrophosphate. And farnesyl can either be dimerized or itself, and where it's a geranyl, and that can be added to a protein, or it can itself be added to a protein. And that's a post-translational modification that happens to some proteins. So, and that farnesylation or geranylation is called prenylation, because the group of these molecules are prenyl molecules. So what is the role of prenylation why does a protein need to be prenylated? So a prenyl group is a sort of a fatty group, a lipid kind of group that's added to the protein. So that will increase its solubility in a lipid medium. So it helps in localization to the membrane. I don't think the science behind this is 100% settled. There's still other reasons why prenylation will help a protein. But we know for sure that small signaling molecules like Rho, if they are not prenylated, move less from the cytosol to the membrane. And there's other signal transduction proteins that are also have prenylation, and reducing their prenylation alters their function in subtle ways. So this is a review article on statins and endothelial cells. So statins make endothelial cells make more nitric oxide. So in a very complicated way, there's a number of different ways why this happens. So the sort of main mechanism I've gone through is via the prenylation protein on the prenylation route on the right here, where you get increased eNOS expression because of altered prenylation of Rho and Rho family proteins. But there are also other changes in the lipid composition that'll change an endothelial cell in microRNA expression that may be direct or indirect that can increase eNOS expression. So it's quite complicated, and there are a number of different mechanisms. So we wanted to do statins inhibit platelets. So why do we do that? So NO is the most potent, second most potent in vivo inhibitor of platelets. So we wanted to statins inhibit platelets. So platelets are also a nice place to look at signal transduction, because there's a number of receptors, signaling networks, and then a platelet is activated and aggregates. So all the work I'm going to talk about in the next 6 slides was done by my grad student, Ran Ni, who's now a research scientist at Affinity Biologics in Ancaster. So what we did was we fed mice atorvastatin in their chow. So we got the diet specifically made by a company, and we sent them atorvastatin tablets. They crushed it and put it in the food. So the dose was how many milligrams per kilogram of food they ate. The mice ate well, they gained weight normally, they were healthy, there were no problems with them. And then we evaluated various markers of platelet activation in vitro and in vivo. So here you can see that in platelets treated with atorvastatin, which is the 2 doses in the red compared to control in the blue, there's significant reduction in ADP-induced platelet activation. So John A is a measure of the marker that changes on a platelets to make it aggregate, and P-selectin is granule secretion. So the platelets aggregate less and secrete less of their granules to ADP, to thrombin peptide, to collagen, to thrombin, and the same to thrombin peptide, collagen, and thrombin granule secretion. So wild-type platelets are sensitive to statins. It's not a massive effect, but it is a 50% reduction in activation. So then we asked what happens if you do this in mice that are lacking endothelial nitric oxide synthase, so eNOS deficient mice. So we know that eNOS deficient mice are prothrombotic and have hyperreactive platelets. And what you can see here is that instead of the statin inhibiting aggregation to all agonists, it seemed to be localized to just thrombin and the thrombin peptide. So collagen activation wasn't affected, ADP activation wasn't affected, just activation to thrombin and the thrombin peptide were dependent on the statin independent of eNOS, okay? So then we were excited and we said, okay, well, let's see what happens in vivo thrombosis model. So this is the model that we commonly use in our lab, which is a thin muscle, the cremaster muscle in mice that surrounds the testicle, and we zap a 50 micrometer arterial with a laser, and you get a thrombus that forms. And you can see that even though the statins inhibited platelets, they didn't affect the thrombus size at all. So after a lot of work, we actually figured out what was going on. So what happens is that what these graphs show is that the platelets in the thrombus, they accumulate normally, but they activate slower, okay? So this is the time until they're half maximally activated in vivo in the mouse. And you can see that the statin makes that happen longer. So the platelets accumulate, but they activate slower. And if you do that in the eNOS deficient mice, you can see they're activating quicker than the control mice, but they're still activating slower if they're treated with a statin. So this, after quite a long time, was published in ATVB. Ren essentially did her whole PhD on this. So, the ongoing work is to figure out how this works. So statins can inhibit platelets in a whole number of different ways. Just through this NO pathway, there's a number of different ways that increasing NO can inhibit platelets. So the most commonly known mechanism is to increase cyclic GMP, but there are far many other mechanisms. All right. So what about venous thrombosis? So we can't do this without talking about mouse models of venous thrombosis, which is one of my pet topics. So mice don't get venous thrombosis, okay, spontaneously. Even mice that lack antithrombin or protein C, where you would expect them to get spontaneous venous thrombosis, they don't. If you have homozygous mice for antithrombin deficiency or protein C deficiency, they have what happens in humans. They get born with Purpur fulminans kind of condition. So there's no spontaneous venous thrombosis in mice. So the only way we can study it is by doing something. So the vein has to be injured in some way. So we choose a vein like the inferior vena cava or the femoral vein are commonly used, and then we do something to them. So scientists have come up with these things, and I like some more than others. So the most common one is where they take the inferior vena cava and they tie a suture around it and they tie it off. Okay, and then they put that back. They sew the mouse back up, and that's their DVT model. So, as a clinical thrombosis doctor, when you see an ovarian vein thrombus after someone's had an oophorectomy, you don't really care, right? Very much, unless it's extended into the inferior vena cava. And I kind of think of this model a little bit like that. Like, I don't think it's pathological for a vein to clot if it's tied off, okay? So they modified that model a little bit where they do this, what they call a stenosis. So before they tie off the vein, they'll stick some other material in there as a spacer, and then they tie it off. And then once it's tied off, they take the spacer away. So the vein is sort of like an egg timer. There's a stenosis there. And then they put the vein back and they image the mouse a few days later, either by histology or some other mechanism. Other ways to irritate or injure the vein would be to use an irritant chemical like ferric chloride, which is what we do sometimes. Or there are other chemicals, and there are even some studies on people using high doses of light to sort of injure the blood vessel with light. Okay, so here's quite a big paper that was in PLOS One in 2015, and they gave mice statins, and they did it by gavage. So I don't know why they have to they essentially put a tube down the mouse's mouth every day for 2 weeks to deliver the atorvastatin or rosuvastatin at 2 different doses. And they did the IVC ligation model, so the tie-off model, and measured the mass of the thrombus day 4, day 7, and day 10. And you can see that the statins reduced the size of the thrombus. There were some time effects, but just generally they reduced the size of the thrombus. And then sort of excitingly, they also showed that after that, after the thrombus forms, it sort of resolves over time. And they came up with a measure called percent thrombus resolution. So what it is at day, say 2 weeks later, what size it is compared to its peak size. And they showed that in the statin-treated mice, their thrombi resolved quicker. So this is interesting. And then they also took the histology of the veins and showed that the veins in the statin-treated mice had less inflammatory markers. So Ly6G is a marker of neutrophils. Histone marker, net markers, citrulline H3, MAC3 is a macrophage marker, myeloperoxidase, again, a neutrophil marker, is reduced in statin-treated thrombi. And then they looked at inflammation, so the thickness of the vessel wall, how that responded to the thrombus, and the statin mice had less thick vein walls. So this is nice and kind of trying to prove that statins might do something in DVT. This is another model which just sort of showed the same thing in rabbits. So they used the IVC stenosis model. So this time, instead of tying it off completely, they leave this little gap, and you can see this heparin reduced thrombus size, simvastatin reduced thrombus size, and heparin and simvastatin sort of were good together. And if you look at the inflammation in the vessel walls, when they analyzed it, you can see that the combo of heparin and simvastatin reduced the amount of inflammatory cells in the vessel wall and the thrombus 2 weeks after the thrombus was formed. So this is something that I found looking for information, the latest on this, because I hadn't touched it in a couple of years. So there's a UK Biobank study simulating statins in patients and in people in the UK Biobank, which is 500,000 people, and they suggest that statins decrease testosterone and they decrease it more in men. You can read that study; it's kind of interesting. So the conclusions of what clinical clinicians can take from basic science work on statins and VTE and VT inflammation is that rodent models suggest that statins can reduce DVT size and improve resolution, but there's certainly imperfect models of DVT, and as a model of post-thrombotic syndrome, I think they're even poorer. We're just looking at inflammation in the thrombus and inflammation in the vessel wall, and thus obviously we need clinical studies to determine if statins can help this unmet need. Thank you. Dr. Toulouk.
Thank you. Thank you. Thank you for the nice introduction. So I have nothing to disclose for this presentation. Apparently it says that I can control, but I can't. Yes, sorry. Yes, so after this excellent presentation on the lab work for statins and thrombosis and VTE, my objectives now is to review the association between statins and risk for VTE and VTE recurrence. I also have a quick teasing for PTS syndrome, and we'll finish with future clinical studies on statins in VTE. So do statins prevent VTE? So we're going to review why there is an interest on statins in VTE, and then statins for primary prevention of VTE, secondary prevention of VTE and PTS, and our future directions. So traditionally, venous thromboembolism and atherothrombosis is considered as two different entities with a different physiopathology, stasis and hypercoagulability for VTE, endothelial injury for atherothrombosis. They are also opposed by their location, mostly the lungs and the lower limbs for VTE, and mostly the heart and the brain for atherothrombosis. And finally, they are also opposed by their therapeutic management, anticoagulants for VTE and antiplatelet therapy for atherothrombosis. And for this presentation, I should add statins or lipid-lowering drugs, mainly statins, in atherothrombosis, which is not the case now for VTE. So we consider these two entities are quite separated, but since the mid-1990s, there has been numerous publications on links between arterial thrombosis and venous thromboembolism. So few publications in the 1990s, but then with the publication of this case control study, there has been a huge number of publications on the topic. So in this study, Prandoni assessed the presence of carotid plaques, asymptomatic carotid plaques, in patients with an unprovoked VTE, in patients with provoked VTE, and in control subjects. And you can see here the proportion of plaques that were found in these patients. Even after adjustments for potential confounders such as age, sex, presence of risk factors for arterial disease, they found that patients with an unprovoked VTE had 2 to 2.5 times higher risk of presenting with concomitant carotid plaque as compared with patients with provoked VTE or control subjects. So this is for asymptomatic atherosclerosis. A few years later, there was this publication of a Danish cohort case control study, 25,000 DVT cases, 17,000 PE cases, and 160,000 controls. And they found that after adjustment for potential confounders, patients with an index DVT had a 1.9-fold increased risk of developing MI or stroke in a year following the DVT event. And in patients with PE, this risk was higher, 2.7-fold increase in the risk of developing symptomatic myocardial infarction or stroke in the year following the index PE. Interestingly, this risk persists over time. So even if it's much lower after the first year, you can see here that patients with DVT or PE continue to have a 1.5-fold increase in the risk of developing symptomatic atherosclerosis as compared with healthy controls. This risk is probably lower in patients who had a provoked event, but the quality of the data is not clear regarding the presence of a provoking event in these patients. But overall, patients with VTE have a higher risk of developing an symptomatic atherothrombosis, mostly in the year following the index VTE event, but also in the long term. So how can we explain this association? So one of the potential explanation, of course, is looking at risk factors. So I listed here the main risk factors for atherothrombosis and VTE, and it's clear that some of the risk factors are common, such as age, obesity, exposure to estrogens. Some of VTE risk factors may be associated with a higher risk of symptomatic atherothrombosis, such as thrombophilia or surgery. And what about the traditional cardiovascular risk factors for atherothrombosis and their association with venous thromboembolism? So we're talking about statins today, lipid-lowering drugs. So it made sense to look at the association between dyslipidemia and the risk for venous thromboembolism. And so we did that in our case control study already 10 years ago. So we took cases of patients with unprovoked VTE. They were matched with controls. The matching factors were age and sex. And we measured their lipid panels. And you can see here in this slide that there was an association between elevated cholesterol, LDL cholesterol, and the risk for venous thromboembolism. So a 1.5 to 2.8 increased risk in developing a first VTE event. These patients with VTE were patients with the first unprovoked VTE. So if you find an association between dyslipidemia and venous thromboembolism, it is tempting to look at lipid-lowering drugs. If you can treat the risk factor, then maybe the event, the disease, will not occur. And so here comes the interest on statins. So as Dr. Gross previously said, the effect of statins extend beyond their lipid-lowering activity. So it's appealing to look at statins in VTE because if there is this association between high cholesterol and VTE, then lowering cholesterol will probably help reduce the risk of VTE, but also the pleiotropic effect of statins may play an important role in reducing the risk of VTE. And I won't go again on this presentation that you just had, but there is evidence that statins improve endothelial function, they modulate inflammation, they maintain plaque stability and inhibit thrombus formation. So although these properties are more studied in arterial disease, there's some publications on the association between rosuvastatin and platelet reactivity, fibrinolytic potential, thrombin generation in patients with a VTE event. So there is an interest in statins in VTE as well. So again, we looked in our case control study on the association between lipid-lowering drugs, here statins and fibrates, and the risk for venous thromboembolism. So very surprisingly, we found that fibrate exposure was associated to a twofold increase in the risk of developing venous thromboembolism, again, a first unprovoked VTE event, whereas statin use was associated with a decreased risk of first VTE event. So this study cannot provide a significant association between statins use and risk for venous thromboembolism, but the trend is quite significant. The point estimate is significant, and you'll see later that it was confirmed in other studies. But these results are important because they bring they highlight the fact that yes, statins may reduce the occurrence of VTE, but maybe this reduction in VTE rates is not fully mediated by lowering cholesterol, because fibrates also lower lipids, and here they are not associated with a reduced VTE risk. So we were not, of course, we were not the only researchers to have a look at statins and VTE risk. And here you have the latest meta-analysis on cohort studies that assess the association between statins exposure and venous thromboembolism. So a quick note on type of statins here. It's not a randomized study. It's not a prospective cohort that specifically assessed statins in VTE. So it's observational, and by definition, if it's observational, you don't decide which patients received what, and so it's a mix of all the statins. However, you can see in these cohort studies that the exposure to statin is associated with a significant 25% reduction in the overall risk of venous thromboembolism. This is confirmed for the risk of deep vein thrombosis. No association was found for pulmonary embolism, but it's only one study, and all of the other studies compiled VTE as DVT and PE. They didn't look at subgroups. So overall, we can be confident in saying that these studies, they show an association, a protective association between statin exposures and VTE risk. So observational studies are good. Randomized control studies are better. So Dr. Gross already mentioned the Jupiter trial. So Jupiter was a trial that included 17,800 patients with no previous vascular events, either arterial or venous. And these patients were randomized to receive either rosuvastatin, 20 milligrams daily, or a placebo. And after a median exposure of 2.5 years and a follow-up of up to 4 years, there was a reduction in the occurrence of a first VTE event. As previously mentioned by Dr. Gross, there are some subgroup analyses, but as mentioned again, the absolute rate of events was very low, so subgroup analyses were not very helpful and underpowered. But overall, there is this association, there is this effect. It's more than an association, now it's an effect because it comes from a randomized trial. Some limitations to this trial, although, are that it was a secondary outcome of the Jupiter trial. So VTE was a secondary outcome of the Jupiter trial. So if you multiply analysis, you know that at some point you may find a positive or a significant association by luck only. And the second limitation was this very low rate of venous thrombosis events. And if you calculate the number needed to treat to prevent one event is more than 700 patients. So there is evidence, good evidence, that statins can prevent a first VTE event, but for sure this is not to implement in health policies. You shouldn't give a statin to every people to prevent a VTE event. It's too few patients or too few people who will develop a VTE event. So now what about statins for secondary prevention of VTE? This table summarizes the recurrence rates over time since diagnosis according to thrombosis risk factors. So I don't want to go through all the clinical situations, but this table is to show that despite our best anticoagulation therapies, despite our best management for stratifying the risk for venous thrombosis recurrence in our patients, on treatment and off treatment, there was still a significant number of patients who will have a thrombotic recurrence. So using statins in this setting is very appealing because statins don't increase the bleeding risk, and they can be a very helpful adjuvant to anticoagulation, or can be administered after completing a course of 3 to 6 months of anticoagulation in our patient, with a possible reduction in the risk of VTE, with again a few risk for adverse events. So again, in our cohort of patients almost 10 years ago, we looked at the risk for VTE recurrence after a course of anticoagulation in unprovoked VTE patients. So all patients received between 6 to 12 months of anticoagulation and stopped their treatment. They were subsequently followed up for venous thrombosis recurrence. So our patients had a mean age of 60, 40% were men, and you can see they had the usual distribution of sites of index VTE, with 30%, or sorry, 50% of patients with an isolated DVT, and the remaining with a PE associated or not with DVT. And so during follow-up, we can see here that patients using statin had the same rate of venous thrombosis recurrence as those non-users of lipid-lowering drugs. And again, we found this negative association between fibrate exposure and risk for venous thromboembolism. So patients on fibrates had, again, a twofold increased risk of venous thrombosis recurrence. So these results were a little bit disappointing because we were hoping that patients exposed to statins will have a lower risk of recurrence than non-users, but it doesn't necessarily mean that there's no effect, because we don't know what would be the rate of recurrence of these patients if they were not exposed to statins. Maybe their recurrence rates would be between fibrates and non-use of lipid-lowering drugs, and so now we can decrease their risk to patients not non-users of lipid-lowering drugs. So this was a small cohort, only 432 patients. Quickly after, there were other larger cohorts that were published from the Netherlands, Canada, and the United States. In this first study, the authors could show a reduction in the risk of recurrent thrombosis in patients receiving statins as compared with those non-users of statins. Here, Dr. Tagarakis could study 25,000 patients, so it was a good opportunity to look at subgroups. And in all different subgroups, she found a consistent association between current use of statins and a lower risk for VTE recurrence so consistently across sex categories, in provoked or unprovoked VTE events, in patients currently on anticoagulation or off of anticoagulation, across different age categories, and also depending on the site of initial thrombosis, there was no difference in the protective effect of statins users. At the same time, a smaller study also confirmed the protective effect of the protective association of statins for VTE recurrence in different subgroups. And here they added that obese and non-obese patients had the same trends in benefit from being on a statin. So again, when there are observational studies, there is a meta-analysis. This meta-analysis was published 2 weeks ago and looked at observational studies that assessed the risk for VTE recurrence associated with statin exposure. And the sum of these studies showed that statin users had a 25% lower risk for venous thrombosis recurrence. The main interest of this study is that they could have a look at different subgroups. And again, consistently across subgroups, there was a protective association between statin use and VTE risk in patients on anticoagulation or off of anticoagulation, in patients whose initial site of thrombosis was a DVT or a PE. And finally, in both sex, in patients with provoked or unprovoked VTE, and in obese and non-obese patients. So definitely there is evidence from observational studies to support the efficacy of statin to prevent recurrent VTE across all the categories of patients, but there is no randomized trial for now. Before moving to the last part of the presentation, I have two interesting slides to tease you a little bit more on the potential interest of using statins in our patients. There is some biologic rationale for statins to reduce the occurrence of post-thrombotic syndrome. An analysis from the SOX trial showed that higher levels of inflammatory markers, including CRP, IL-6, IL-10, and ICAM-1, were associated with the development of PTS. And there are some lab studies and animal models that suggest that rosuvastatins could inhibit the expression of ICAM-1 in a dose-dependent manner, but ICAM-1, you can see that it's clearly one of the common markers of inflammation in those two studies. So does it happen in clinical studies? Well, we have a low level of evidence, but still evidence that suggests that statin use could be associated with a reduction in the occurrence of PTS. The first study that I show you here is a retrospective observational study of 579 DVT patients from a single center, and they showed that patients who were exposed to statin had a 30% reduction in the occurrence of PTS. There was a randomized controlled trial of 234 patients with an acute DVT who were randomized to receive low molecular weight heparin plus rosuvastatin or low molecular weight heparin alone for 3 months. So this study was not powered to demonstrate a difference between clinical outcomes in both groups. It was powered to determine a difference in biomarkers, but they observed as secondary and clinical outcomes that their patients on statin had a lower mean Villalta score as compared with those on low molecular weight heparin alone. And patients with post-thrombotic syndrome after 3 months of treatment were less frequent when they received rosuvastatins as compared with no rosuvastatin. So fuel for ideas, fuel for trials. And with this, I'm going to go to the future directions on VTE and statins, or statins and VTE, to have a quick look at the SAVOR trial. So based on all these observational studies, there is clearly room for a randomized trial to assess whether a statin can reduce the risk for venous thromboembolism recurrence. And you are well aware that Dr. Roger has successfully completed the SAVOR pilot and demonstrated the feasibility of a larger trial that will assess rosuvastatin to prevent venous thromboembolism recurrence. So we are about to open our center for this international multi-center randomized controlled trial of 2,700 patients with asymptomatic proximal deep vein thrombosis or pulmonary embolism who will be randomized between receiving rosuvastatin 20 milligrams once a day as an adjuvant therapy to anticoagulation at least 3 months or to receive placebo on top of the standard therapy. So the patients will be randomized and stratified according to their centers, to the presence of a provoking factor, and the choice and the duration of anticoagulation will be at the investigator's discretion. Our aim is to treat these patients for 6 to 60 months. It's going to be an event-driven study. We plan on a median follow-up of, a median exposure to treatment of 2.53 years. And the primary objective of the study is documented recurrent VTE. One of the secondary outcomes of the study is whether rosuvastatin can prevent the post-thrombotic syndrome. This study was funded by CIHR, and again, some of you will very likely participate in the study, and we are going to implement the study in Europe in the coming months. So to conclude, there is evidence that statins are effective for primary prevention of VTE. There's also evidence that they could be an adjuvant to anticoagulation or to standard of care to reduce the rate of recurrent VTE in all types of VTE event, DVT, PE, provoked, unprovoked, regardless of age, sex, or weight of the patients. Also, there's little evidence that statins could reduce the occurrence of PTS after a deep vein thrombosis. And we hope that we will answer these important questions with the SAVOR trial. Thank you very much for your attention. And I think we have enough time for the questions.
Thank you very much, Dr. Gross and Dr. DeLuc. These are fantastic talks, and we've received a few questions. So actually, in fact, Dr. Conway submitted like 6 questions altogether, but I think they're all great questions. And maybe I'll just direct them sort of to you both, because you do have overlapping areas. So basically, you know, Dr. Conway says great talks. So would you not suggest that everyone be on statins for primary prevention? Maybe we can get Peter to answer that. And then maybe what are the downsides of long-term statins? From what age? Any sex differences in benefits and during pregnancy? And maybe we can get, you know, Aurélien to respond to those clinical questions. So Peter, I think you had maybe touched base on the primary prevention already.
So, you know, you don't want to expose a drug to a population if there's a small chance of harm. And so the harms that have been proposed to statin on the clotting standpoint, there's one stroke study showed a small amount of increased hemorrhage. So that's a possibility that's actually real, and, you know, that's a possibility. The UK Biobank study is an interesting thing to read because it essentially posits that statins may reduce testosterone, and, you know, that may be a good thing for cardiovascular and venous health, but it may not be the best thing for health. The third issue is that I still haven't seen this correctly, but there have been some studies about statins and neurocognitive issues, and some concerns that there may be some neurocognitive changes that happen in people on statins, and I don't think we're completely clear of saying that doesn't happen. So I don't think they're magical and have no bad problems, and so that, I think, limits ideas of giving it to everybody.
Yes, of course, I agree. I would not offer us taking a statin for primary prevention, either for primary prevention of VTE in the whole population, but maybe if we demonstrate that there is a subgroup that will benefit from it, okay, why not? But there's also some side effects to statins. They are not very frequent. The serious adverse events are not that frequent, like rhabdomyolysis or sometimes autoimmune myopathy. But many patients describe some muscle discomfort while taking statins, and I don't think that it's worth the price to offer a statin to every people for primary prevention.
Thank you. So to follow up with sort of that line of question, I think, Peter, you had talked about the testosterone differences and, the differences with fibrates as well, where, fibrates low cholesterol, but we don't, see that benefit. So we don't see the benefit with fibrates in lowering thrombosis. So clearly it sounds like it's not the impact on the cholesterol, and I think you showed studies that maybe it's actually on platelets and so on. Has there been any studies looking at, are there synergistic effects between like an antiplatelet agent plus a statin in this setting in terms of preventing venous thrombosis? Because, there's a lot of patients who like to use aspirin for secondary prevention, even for VTE, right? Because it's cheaper, maybe they don't want to do drugs. I still have patients who say, I'd rather take an aspirin instead of a DOAC sort of thing. And I mean, has there been that, the combination?
I don't think there's any, but you're right. I mean, for patients who don't want to pay for their anticoagulants as long-term prevention, if they take aspirin, maybe they could take aspirin and statins. Statins are very cheap as well, and if there's a synergistic effect, then maybe we could further reduce the risk of recurrence. There is an effect of aspirin on VTE recurrence. So if we demonstrate that statins can help, then yeah, it could be an option. But again, this population is at a higher risk for VTE recurrence, so it's worth preventing it with statins in these patients rather than for primary prevention. Sorry.
So then, like in the SAVOR study, then presumably are you allowing patients to be on aspirin? Is that a particular subgroup? And also, I think so. Dr. Steve has a question about just the feasibility of doing a placebo study, controlled study for 5 years.
That's right. That's right. So the SAVOR pilot was an open label trial, as she mentioned in her question, and it's true that the fact that we are going for a placebo controlled trial will make inclusions much harder. The reason why we chose a placebo trial was first because it's of course, a better level of evidence, and also because it was highly required by CIHR when they reviewed the grant. They said, okay, from one previous review, they said you definitely should do a placebo-controlled trial, and that's because they asked that we submitted a proposal for a placebo-controlled trial. So we will start as a placebo-controlled trial, and we will see if we face a lot of refusals because there's a placebo. Then we may change our protocol, but we will start with a placebo.
Thank you. Another question about CRP. So in SAVOR, do you have are these patients who have an elevated CRP? Are you using that? Are you recording that? Because in Jupiter, I recall that those were patients who actually had an elevated CRP, were randomized, right? So it wasn't just all comers.
Yes.
So there is targeting a, specifically, presumably, an anti-inflammatory effect. So is SAVOR also looking at that as well?
So that's right. In Jupiter, one of the inclusion criteria was an elevated ultrasensible CRP. We don't. In SAVOR, we make it as pragmatic as possible, except that there is a placebo. But basically, if you don't have an indication for secondary prevention of MI, stroke, peripheral artery disease, then you are eligible for the study. And if you don't have diabetes, if you don't have a strong indication for receiving statin.
But are you collecting CRP at baseline then?
No, we don't. No.
Okay, nothing. So you don't know if that will turn out to have a difference in terms of.
No.
Okay.
No.
Okay. And just going back to the many questions Dr. Conway has, and they're great. Going back in terms of fibrinolysis, I think, Peter, you had mentioned some data that the clots actually, resolved faster when they were on the mice were, were fed statin. So perhaps, is that an impact on, you think, the fibrinolytic pathway? So again, totally independent of platelets and so on, or do you think it's just maybe somehow the clot formation is different so that when they're formed on statins, somehow they get lysed better or faster? So
I think either is possible, and I don't think there's any evidence directly asking whether there's fibrinolytic enhancement with statins. If you get a smaller clot, it lyses quicker, right? So I don't think there's direct fibrinolytic, pro-fibrinolytic evidence, but that's a good question.
And so I guess, Peter, I won't ask you, so do mice get PTS?
They don't get PTS, they just get these inflammatory cells in these models of venous thrombosis, right? So, it's not a good model, but it is a inflammation in the thrombus, around the thrombus. Now, is that PTS, or is that, things that are there to lyse the thrombus? Are those immunomodulatory cells good, or are they bad? I think the lack of a mouse model for PTS is hampers progression of the disease, progression to a therapeutic in that disease, which needs a therapeutic. There's a couple of trials that have been abandoned because I don't think they kind of knew what to do with how to look at PTS. So, inflammatory inhibitors, so something that stops P-selectin and its ligand from interacting. There was a trial in DVT patients that was recently stopped for no benefit, but I don't think they really knew how to pick people who were going to get PTS and really knew how to measure PTS, and so I think that's a problem. We just don't know whether these cells immune function is very complicated. It's a battle with shots fired both ways, and I think you need to. I don't think we know enough.
Thank you, Peter. Any questions from either of you actually for each other, or any other final comments? Because we're at 12:32, so I'm aware of time and everybody needs to get back to their day. No? Well, thank you very much, both of you. Fantastic talks, and I'm glad I certainly was able to make it, because I've always wondered about, whether, we should just be, putting everybody on statin. It makes sense, but certainly there are long, perhaps some significant side effects that we should be aware of. And good luck with the SAVOR study. I think that's really going to be, outstanding if we can, really have a definitive answers, because there's certainly a lot of compelling observational studies, results there, but we all know the limitations for those studies. So just a little bit of housekeeping. So make sure you submit your points for Royal College for your maintenance of confidence. Our next seminar is in February. Right now, tentatively, I think it's actually February 24th, and we're going to have Dr. Skeeth to talk about her PARTM study, and Dr. McGuire also to provide some scientific background on that. You can see on the slide right now that we also have a March and April seminar planned ahead of time too. So we look forward to seeing everybody again in next month. And if you have any comments and so on, any concerns, please let us know. The past events are available to stream at CanVector. I'm not sure there's a time limit or anything for them. I think they are just up there. So I certainly would encourage everybody to go back to the previous seminars if you've missed them, because they've all been great. So thank you again, everybody. Have a great day, and hopefully you've all had your vaccines, and your second dose will be coming shortly if you've had your first one. Bye-bye.
Thanks, guys.